Now, what do you mean by a cholesteatoma? Cholesteatoma is a three-dimensional epidermal and connective tissue structure which is frequently confined to the architecture of mid layer and mastoid, and it has got a capacity for invading and displacing the underlying bone and has got a tendency to recur even after its removal. This is the Abramson's definition for cholesteatoma. You need not know all this. Okay, you just have to know that cholesteatoma is simply skin in the wrong place. Skin means the keratinized squamous epithelium, which was not supposed to be present within the mid layer. When it gets into the mid layer, that is resulting in cholesteatoma formation, because when the macrophages senses that there is something which should not be present within the mid layer, they gets activated and goes on to engulf them. Okay, when they get activated and goes on to engulf them, it elicits an inflammatory reaction all over the mid layer, and that results in granulation tissue formation after otitis and bone erosion occurs, and this can result in various complications. That is why it was also known as unsafe CSOM. Okay, unsafe CSOM. Tuberculous disease was called safe CSOM. This was called as unsafe CSOM because there is more chance of complications occurring here because of the propensity for bone erosion. Okay, now what are the types of cholesteatoma? I told you there is congenital type, and congenital cholesteatoma, unlike the other cholesteatomas, it is seen medial to the pars tensa. Okay, it is seen in the anterosuperior quadrant, unlike in others where it is in the posterior superior. Here most common site is anterosuperior quadrant. Okay, anterosuperior quadrant is the most common site of congenital cholesteatoma. Okay, now in a case of congenital cholesteatoma, there is a criteria to be satisfied. That is what is called the Levenson's criteria or the modified Derlaki and Clemmis criteria. Okay, Derlaki and Clemmis criteria, and this is something which you have already learned. Okay, modified Derlaki and Clemmis or Levenson criteria, right? Have you learned? No, actually you have learned Levenson criteria for malignant otitis externa. Okay, not this one. That is another thing. Okay, this is another thing. Now in Levenson's criteria, what are the things that you have to know? There will be a white mass which is seen medial to the tympanic membrane, and there will be a normal pars tensa and pars flaccida, and there will be no history of ear discharge, no history of any surgery, and recurrent bouts of any otitis media is not a criteria for exclusion. Okay, so these are the various things discussed by the Levenson's criteria for congenital cholesteatoma. And from where does this arise? It arises from the congenital cell rest. Congenital cell rest within the mid layer, CP angle, and various other areas where it is present. From this embryonic cell rest, it forms stratified squamous epithelium and can result in bone invasion. Okay, now coming to the secondary acquired cholesteatoma. How does it occur? It occurs through a pre-existing marginal perforation. Okay, through the pre-existing marginal perforation. What is this marginal perforation? I already told you when I told you about acute necrotic otitis media. When the margin of the perforation, that is the tympanic annulus, is lost, it can result in a growth of cholesteatoma within it. Okay, that is occurring because of the secondary acquired phenomenon. How? Because the tympanic annulus, when it is lost, there will be no contact inhibition and the stratified squamous epithelium can grow within. Okay, and that can go and result in the bone erosion. Okay, so this is what is known as the Haberman's theory. Okay, Haberman's theory of cholesteatoma formation. So this is the theory for secondary acquired cholesteatoma. Now for primary acquired cholesteatoma, there are various theories like Said's metaplasia theory. It says that it is due to the metaplasia that is happening, the cholesteatoma formation. Due to the repeated infection, there is metaplasia occurring in the medial part where you have a mucosal layer. There metaplasia happens and that results in formation of stratified squamous epithelium. And there is Rudy's theory of basal cell hyperplasia. It says that it is due to the repeated microtrauma. Okay, repeated microtrauma results in the basal cell hyperplasia to occur. Okay, repeated microtrauma. So this is the other theory, and the final theory, which is the most important theory for primary acquired cholesteatoma, is the Wittmach's theory. Okay, Wittmach's theory. Wittmach primary acquired. Okay. Now, what is this Wittmach's theory? It says that due to the retraction pocket formation, there is a chance for formation of cholesteatoma to occur. Okay, how is this retraction pocket being formed? What is this retraction pocket? It is a localized area of retraction, and I told you the most common site of retraction to occur is the pars flaccida and the posterior-superior part of the pars tensa. And here, why is it occurring? Because of the negative middle ear pressure occurring due to the eustachian tube obstruction, and this can predispose to a serous otitis media as well. And along with that, this retraction pocket formation also occurs. And you have already learned about the retraction that is occurring in pars tensa, right? Now, for retraction in pars flaccida, there is another classification. Okay, pars flaccida is on the top, and so the classification here is TOS classification. Other classification was Said's classification, right? This TOS classification. And according to the TOS classification, you have the type 1 where there is only an attic dimpling. Okay, one is attic dimpling. In the stage 2, what you having? The stage 2, it goes on to touch the neck of malleus, as you can see here. Touches the neck of malleus. In stage 3, apart from touching the neck of malleus, what is happening? There is limited attic wall erosion. Okay, limited attic wall erosion. In stage 4, there is marked attic wall erosion. Okay, so this is what is happening in the classification of pars flaccida, which is called as the TOS classification. And what happens after there is the scutum erosion? There is a perforation formed in the pars flaccida, and you will be able to see the cholesteatoma or the stratified squamous epithelium with the keratin debris within. Okay, that will be clearly visible as flakes. Okay, and there will be a perforation. All these are the features of a pars flaccida cholesteatoma. What is the most common site of cholesteatoma formation? It is the Prusac space. The pars flaccida cholesteatoma, it will go into the Prusac space due to the retraction, and here it forms the cholesteatoma which will erode the head of malleus and the body of ingus in the attic, and from there it can spread into the mesotympanum through the tympanic isthmus, and it can erode the ossicular lenticular process of ingus and the stapes suprastructure, right? And the pars tensa cholesteatoma can also go into the attic through the tympanic isthmus like this. Okay, it can go above and then it goes into the facial nerve, lateral semicircular canal area. All these can get eroded and can result in the various complications of chronic otitis media, and hence it is called as the chronic otitis media unsafe type. Now, what is the treatment of a naticoandral disease or a chronic otitis media squamous cell disease? We will have to remove the whole of these keratin flakes or the cholesteatoma debris have to be removed completely from the mastoid as well as the mid layer. And how is it being done? For that you will need to do a surgery. There is no medical treatment for the condition. Okay, and what is being done? You will do drilling of the mastoid. Okay, and what is the surgery that is being done? We know that cortical mastoidectomy is a surgery which is done for mastoid abscess, and cortical mastoidectomy earlier days it used to be done even for a tympanoplasty. Along with tympanoplasty, when you are doing a tympanoplasty to make the otitis patent. Okay, sometimes otitis patency can predispose to recurrent infection. Okay, in that case also a cortical mastoidectomy used to be done. So the first step will be a cortical mastoidectomy when you are doing a modified radical mastoidectomy. Okay, how is this being done? First of all, you will have to do a postoral William-Weil's incision as shown. Then you will have to put the periosteal incision. A T-shaped periosteal incision is put and the flaps are elevated, and then you start drilling. This is how you put an incision, and then you retract the pinna forwards, and then you put the periosteal incision. And what is the instrument that is used there? Yes, there is a self-retaining hemostatic mastoid retractor. Okay, Mollison's self-retaining hemostatic mastoid retractor has been used. I will be taking a separate class for your own instruments, then you will get an idea. For now, just remember a self-retaining hemostatic mastoid retractor has been used here, and along with that you will be using a drill. And what is the drill that is used? A cutting burr is used. Okay, cutting burr is used, and the largest size cutting burr is used earlier on. Smaller cutting burrs when used can cause injury, so it's the larger cutting burr that is used, and only when you use a larger cutting burr, more area will be drilled sooner. And while drilling, you always use irrigation, and suctioning also is being done because you have to remove the bone dust. Okay, we have to clear it from the view. For that you have to suction and you have to irrigate. Irrigation has to be maximum when you are using a diamond burr. Diamond burr is used when you are going near vital structures such as the facial nerve. Okay, when you are using a diamond burr, you have to irrigate the maximum to avoid the heat caused by the diamond burr, because if there is heat, the thermal injury also can lead to a facial nerve paralysis. Okay, so that is also important. And now you are drilling in the area of the triangle of attack. Okay, triangle of attack, I already told all these things when I told you about the mastoidectomy, right? Yes, and then what else have to be done? You have to do a modified radical mastoidectomy in most patients with chronic otitis media squamous cell disease, and this modified radical mastoidectomy is a canal wall down procedure. What is this canal wall down? What do you mean by the posterior canal wall? Posterior canal wall is the wall that separates the mastoid from the mid layer and also the mastoid from the extenotic canal. Both are being separated by the posterior canal wall. This posterior canal wall has to be brought down. Okay, and only then you will be able to exteriorize the mastoid cavity into the extenotic canal. Okay, so that is what is being done by removal of the posterior canal wall. But sometimes that is not necessary. What can you do instead of that? You can go for a facial recess approach. Okay, what is this facial recess approach? What do you see here? So that is the facial nerve that you see here, and you have the coda tympani here, and above you have the ingus buttress, and this space is what is called the facial recess. Facial recess is also known as suprapyramidal recess, right? It is called suprapyramidal recess. And when you are approaching the mid layer through the facial recess, that is what is called as the posterior tympanotomy approach. This is a commonly done approach to reach the round window niche. Okay, this is the area of round window niche. To reach the round window niche, to put a cochlear implant during a cochlear implant surgery, you do a posterior tympanotomy. When posterior tympanectomy is done along with anterior tympanectomy, that is elevation of the tympanomeatal flap, along with cortical mastoidectomy to clear disease from the mastoid. Okay, when all these are being done, that is what is called as the combined approach tympanoplasty or CAT. It's called the combined approach tympanoplasty. And when you are doing a combined approach tympanoplasty, you are not removing the posterior canal wall. Okay, this is the posterior canal wall, and when you are doing a combined approach tympanoplasty, you don't remove the posterior canal wall, and that's why it is called as intact canal wall procedure or canal wall up procedure. Okay, so canal wall up procedure example is a combined approach tympanoplasty, and that is a minimally invasive technique because you are having a posterior canal wall intact for the patient, and that means the patient won't have problems like going for swimming and recurrent ear discharge due to some infection or wax in the mastoid cavity. All those problems won't be there, but there is high chance for recurrence when you are doing like this. Okay, the recurrence rate is higher when compared to the modified radical mastectomy. Now, what is being done in a modified radical mastectomy? In modified radical mastectomy, first of all, you have to understand what is this posterior canal wall. Okay, this is the posterior canal wall, right? And this posterior canal wall separates the, this is the anterior canal wall here. Okay, now you have the facial nerve here. Sorry, it's coming like this, goes on like this. Okay, now this is the facial nerve. Okay, and yes, this whole thing is the posterior canal wall, and this posterior canal wall actually will be extending like this, right? Because you have the external auditory canal there, and that same posterior canal wall will be separating it from the mastoid there also. Okay, so this is the mastoid air cells you have here. Okay, now how are you going to do a case of a canal wall down procedure? When you are doing a canal wall down procedure, what you do is you will be removing the posterior canal wall like this. Okay, but when you are removing, you can't remove it completely. You can remove it only until the facial nerve. Okay, so only till here the facial nerve can be removed. So what is the area this removal is being done? This is the area. Here the whole part is getting removed. Okay, but here only this much is getting removed. That is, this area is what is called as the facial ridge, and this part which is getting removed is called the facial bridge. Facial bridge overlies the ossicles, and facial ridge is the part which overlies the facial nerve. And the facial ridge can't be removed completely, it can only be lowered until the facial nerve is reached. Facial bridge is completely removed, and the anterior and posterior buttress are also removed, and so you can easily access the mastoid through the external auditory canal. Okay, now by doing this you can easily access the mid-layer, and all the disease from the mid-layer can be removed, and that is what is known as the modified radical mastectomy or MRM. Now, how does it differ from the radical mastectomy? In radical mastectomy, what else is being done? In radical mastectomy, you are removing the whole of the mid-layer mucosa, you are removing the whole of the ear ossicles, and also plugging the eustachian tube to prevent any infection coming from the pharynx to getting into the mid-layer. Okay, when is it being done? When you are sure that the patient is having a dead labyrinth. There is no way there is a hearing reconstruction possible. The patient is having sensorineural hearing loss, a dead labyrinth. Okay, there is nothing that can be done to improve the hearing. Okay, in that case you can do a radical mastectomy. So in radical mastoidectomy, the whole of the middle mucosa is removed, the whole of the ossicles are removed except for the stapes foot plate that you have here. That is the oval window area, you have the stapes foot plate. That is not removed. Why? Because if you are removing that, there will be a fistula there, okay, and that can cause a lot of vertigo, imbalance, etc. So that is not removed. That is kept intact there. And apart from that, the whole of the ear ossicles, the middle mucosa and all are removed. And that is done in case of a patient is having a completely dead labyrinth. And sometimes in malignancies of the exhalatory canal within the middle ear, even for glomus tumor also radical mastoidectomy is done. But for an extensive cholesteatoma or any cholesteatoma, modified radical mastoidectomy is preferred. And when you are doing a modified radical mastoidectomy, you will do a meatoplasty as well. Why do you need to do a meatoplasty? Meatoplasty is to allow an inspection of the mastoid bowl after the procedure. Okay, you have to have a routine checkup of the patient every 3 to 4 months, so as to assess if there is any recurrence or if there is any cholesteatoma left behind, if it is coming back, or all those things you can check by simply pulling the pin itself. You will be able to see the mastoid bowl, okay, and that is because you are doing a meatoplasty. You are removing a part of the conga. The congal cartilage is removed and then suturing is done to widen the area, okay, and so you will be able to access the mastoid cavity. Okay, now this is the mastoid antrum. You have the facial bridge here. This facial bridge is removed and the facial ridge is lowered. Okay, so this much area is removed, so you can access this area. Okay, after doing a mastoidectomy, you can access the middle ear in case of an MRM or a modified radical mastoidectomy. When you are doing a radical mastoidectomy, you will be plugging the eustachian tube, you will be removing the whole of the ear ossicles. All these things are being done, okay, in case of a radical mastoidectomy. Okay, now in the case of modified radical mastoidectomy, you are more of dependent on the doctor, but there is less chance of recurrence because there is no way you are going to leave behind any cholesteatoma, because you are having a better visualization of the whole of the middle ear cavity. Whereas in combined approach stimulinoplasty, which is an intact canal wall procedure, there is more chance of leaving behind. Okay, so you can divide surgery for AAD into two: intact canal wall or canal wall down procedure. And this canal wall down can be divided as modified radical mastoidectomy and radical mastoidectomy. But this radical mastoidectomy is not done for a patient who is having cholesteatoma alone. Okay, it is usually done for a malignancy and when you are having a dead labyrinth. Along with an extensive cholesteatoma, only if you are having a dead labyrinth, you will go for radical mastoidectomy. Only in such conditions you will go for radical mastoidectomy. Okay, there is no way you are able to preserve the hearing. Only then you will be doing that. Otherwise, MRM is the choice of squamous cell disease in most cases, but in certain cases you go for intact canal wall in case of limited disease. Okay, and what else can be done? You can actually obliterate the mastoid cavity after doing a canal wall down procedure, and also reconstruct the posterior canal wall so that the patient won't have any cavity problems. Okay, the cavity problems are the main problem with this canal wall down mastoidectomy, because this cavity can cause a vertigo sometimes because of the labyrinthine stimulation, and you can't go for swimming, you can't keep a hearing aid. If you want to keep a hearing aid, you will have to do an intact canal wall mastoidectomy, that is combined approach stimulinoplasty may be needed. Okay, if you are needing to put a hearing aid and you can't go for swimming, okay, swimming can't be done. But what is the main aim of surgery in case of a nephrotic disease? It is to make the ear safe and dry and to reconstruct the hearing mechanism. And for that, the surgery of choice is actually a canal wall down mastoidectomy in the form of modified radical mastoidectomy. And for modified radical mastoidectomy, when you are doing, that is what I told you, you can obliterate the cavity as well as reconstruct the posterior canal wall to avoid the cavity problems. Okay, so this is how when you do a surgery, this is the area of the mastoidectomy. Okay, mastoidectomy is lying deep within. How will you identify it as antrum? You will have to check for the patency of the otitis by putting water, and if it is reaching the middle ear, you have to check for. So this is how a completed mastoidectomy cavity looks like. Okay, after doing a mastoidectomy, complete mastoidectomy, you will have to lower the ridge and remove the bridge to complete a modified radical mastoidectomy. Now, what are the complications associated with it? The complications can be a facial nerve palsy. If you are not careful, you can cause a facial nerve palsy, an inguloscapularis joint dislocation, ingus dislocation, and what else can happen? You can go and injure the chorda tympani nerve. Of course, chorda tympani nerve is always removed in case of modified radical mastoidectomy. There is no doubt on that. So you have to tell the patient there will be an altered taste sensation. But in most cases of squamous cell disease, chronic otitis media, the patient already would have had its chorda tympani injured, okay, because of the cholesteatoma itself. Okay, so the patient won't be aware of the change of the caused by the surgery. Okay, so the chorda tympani nerve injury won't be there if you are doing a canal wall up procedure. Okay, and what are the other complications? A labyrinthine injury can occur. Okay, and this bleeding can occur. All these are various complications, and especially in case of a contracted antrum, a dural injury and CSF leak is very high and likely to occur, and a sigmoid sinus injury can cause a troublesome bleed. Okay, you can see this is the sigmoid sinus here. Okay, if it is injured, there could be a troublesome bleed. It will be very difficult to control that bleed. Okay, so all these complications also you have to remember when you are asked about a modified radical mastoidectomy in case of an aticoandral disease. Okay, so today we have learned about chronic otitis media. We learned about chronic otitis media mucosal disease and squamous cell disease, and also healed otitis media. And why do you need to do a surgery in case of mucosal disease? To make the ear dry and also to improve the hearing of the patient and to facilitate swimming. Only if you are having a patient with intact tympanic membrane, he can go for swimming, right? If there is a perforation in the tympanic membrane, he can't swim, because whenever he swims, there will be infection of the middle ear and that can result in ear discharge, right? And squamous cell disease, the first aim is to make the ear safe, then dry, finally improve the hearing mechanism. And to facilitate hearing, you will have to do a case of combined approach tympanoplasty or intact wall technique. Okay, intact wall technique will have to be done. I know this is going to be a little confusing for you, but you have to read this more and more, because this topic is something which will be a little bit difficult to understand. Only if you see more of videos and then read it up, you will understand this topic, because even for postgraduates it is a difficult topic. Okay, the chronic otitis media, squamous cell disease, the surgery is being done. It's not the theory part. Theory part you can easily understand, right? The squamous cell disease, the types of cholesteatoma being primary, secondary, and congenital. There is another entity called a tertiary one, but that is not usually asked for you. The tertiary origin of squamous cell disease is when it is occurring due to a surgery. After surgery, when you are accidentally putting some keratin debris within the mid layer, and that is causing cholesteatoma formation. That is highly unlikely, okay, and that's not important for you. It is the congenital, primary and the secondary variety that is important for you, and you have to remember the various theories of cholesteatoma. And yes, what are the various techniques? You can do a canal wall down or a combined approach immunoplasty. In canal wall down, there is less chance of recurrence because it ensures a better clearance and better removal, whereas in case of a combined approach to immunoplasty, the patient's morbidity will be less, he will be less dependent on the doctor, he will have to do a routine checkup, of course, he will sometimes have to do an MRI to check for any recurrence, but the patient will be having a better chance of maintaining his health of ear, because you can go for swimming and do all sorts sort of things when you're doing a combined approach to immunoplasty, okay, because the mastoid cavity is not exposed, okay, and if you have done a tympanic membrane repair completely and the posterior canal wall reconstruction is done in case of canal wall down mastoidectomy, to an extent that also decreases the the morbidity, okay. So to decrease the chance of recurrence, it is better to go for the canal wall down mastoidectomy, and combined approach immunoplasty is done to decrease the morbidity of the patient. And nowadays, with the advent of the endoscopes, the chance of recurrence is also being reduced with combined approach to immunoplasty, okay. So there are advocates for both the techniques, there are pros and cons for both the techniques, but when you are asked what is the surgery of choice for a squamous cell disease, still it is combined approach to immunoplasty. Why? Sorry, still it is canal wall down mastoidectomy. Why is it so? The reason is because in most parts of the country, the endoscope are not available for the mid-layer surgery, and it is being done by microscope alone, and so you can't ensure adequate removal with combined approach immunoplasty, and it is a more difficult technique. Okay, you have to go between the facial nerve and choroidal money, right? And so most surgeons are trained with modified radical mastoidectomy than combined approach immunoplasty. So the answer to a question, what is the surgery of choice for squamous cell disease, when you are asked, it is not combined approach immunoplasty that you have to tell. You have to tell it is canal wall down mastoidectomy in the form of modified radical mastoidectomy. And radical mastoidectomy is not done for cholesteatoma, it is usually done for malignancies, glomus tumor, okay, and when you have a dead labyrinth, okay, or a cochlear promontory fistula, okay, all these are the indications for doing a radical mastoidectomy, okay. So that's about chronic otitis media. We will be learning about the complications of chronic otitis media in the next class. For now, goodbye.